fun. Thank you. I appreciate it. Oh, great. Thanks. All right. I'm Hannah. Guys, I actually graduated from UNC 5 years ago now, and I'm a nurse, and I worked for a long time as a trauma neuro nurse, and I'm actually doing labor and delivery now, but my background is in trauma neuro, so that's why I thought I'd come in and present these diseases. I know a lot of you guys are pre-nursing, right? Most of
Majority of the class,
pre-nursing.
right?
Is anyone not pre-nursing? Great. Okay. Sounds good. I like to give hospital examples, but I didn't know if I should do that if anyone was not pre-nursing. But
I can do
sounds
it.
good. Okay, so degenerative diseases. These are, a lot of people actually have these diseases that, you know, come into the hospital, and that might not be why they're here, but they have these diseases, and we still need to know what they are and what they can cause, the symptoms that they have. These are the ones we're going to talk about today: dementia, Alzheimer's, Parkinson's, Huntington's, MS, ALS, and myasthenia gravis. Whoop. Oh yeah. So Alzheimer's. Before we talk about Alzheimer's, we have to talk about dementia, because dementia is like this broad category of a lot of cognitive diseases, and Alzheimer's falls under that category of dementia. Dementia is actually defined as, it's kind of long, but I do think it's helpful, an acquired deterioration and progressive failure of many cerebral functions that includes impairment of intellectual processes with a decrease in orientation, memory, language, judgment, and decision making. So Alzheimer's is one of those things. There's also Lewy body dementia, frontotemporal dementia, and vascular dementia. Alzheimer's is the most common form of dementia. And one thing that I want to stress is dementia is, I think, often seen a lot of times as like a normal aging process. You know, you get old and you forget things, and you know, don't know where you put your keys, and don't know why you missed your doctor's appointment or whatever. This is not a normal aging process, and I think a lot of times people don't get treatment for the first couple, you know, maybe even years of symptoms, because they think, oh, I'm just getting old, you know, I'm getting old and that's why I'm forgetting my keys. This is not normal, but it's easy to brush off, right? I mean, it's very easy to just, I mean, I forget my keys, you know, but it's not normal. No cures for dementia. You can use therapy to maximize all the functions you have left, but no cures. And that's a common theme that you'll see throughout this presentation, is that for a lot of these neurodegenerative diseases, there's not a cure for them, which is really sad. All right, Alzheimer's disease occurs middle to late life, usually later in life. Some people get early onset dementia, and that can happen in like your 40s or 50s, but usually it's a little bit later than that. Leading cause of dementia. Causes. We have some theories, but we don't know what causes it. They think that there might be a genetic mutation on your chromosome 21, that if you have this mutation, you are more likely to develop Alzheimer's. But again, we don't really know. But what we do know is when you do have Alzheimer's, you have these accumulation of neuronic plaques, and these plaques have this amyloid beta protein, and that is a toxic fragment, and it actually causes neurons to die when it has that protein in it. So you have death of neurons, which causes brain atrophy, and then that causes decline in memory, attention, and a lot of other cognitive functions associated with that. You also get these neurofibrillary tangles. The tau proteins in neurons detach, and they form these little tangles that cause neurons to die. So these are two common themes in people that have Alzheimer's, is the plaques and the tangles. Again, atrophy and then the loss of neurons. So picture A is a healthy, normal brain, and picture B is a brain with Alzheimer's. You can see how it almost looks like, the word that comes to mind is dehydrated. Like it's just kind of shriveled, you know? And that is because the loss of neurons in that brain versus brain A, the normal brain. So that's what a brain with Alzheimer's looks like. No fizz. So the neurofibrillary tangles, that tau proteins are kind of wound together, and then they are not able to be broken down. So they are wound together really, really tight, and then they die. The neurons die, but they still have these tangles, and these tangles form together over time to cause plaques. And then these plaques, they're called senile plaques, they disrupt nerve impulse transmission. So when you can't get, the message through, you're gonna have a decline in memory, attention, and other cognitive functions, but those are the main two, memory and attention for Alzheimer's, because of the tangles that form into the plaques. And you can kind of see a picture of them right here. Another thing that happens with Alzheimer's is there's a decrease in the level of choline acetyltransferase. That's a tongue twister. This is an enzyme that's required to make acetylcholine, which is a neurotransmitter associated with memory. So if you don't have the choline acetyltransferase, you don't have acetylcholine, the more severe the dementia is. Does that make sense? It's a direct relationship. This happens because of the tangles in the plaques that are in your brain. You can't make the choline acetyltransferase because of the tangles in the plaques that are already there. So symptoms of Alzheimer's. This is a very slow and gradual process. It doesn't happen overnight, but it starts off kind of subtle and then it gets progressively worse. So classic symptoms, loss of short-term memory. People don't just remember, their doctor's appointments, they forget to go to the store. They'll remember what like a loaf of bread cost in like 1980 or something, but they don't remember little things. They forget to go to their grandchild's soccer practice or something like that. And it's this weird phenomenon because their long-term memory is totally intact. They can tell you stories from their childhood, and if they were war veterans, they love telling you about that, but they can't remember just like basic short-term memory things. And then they also deny that they have memory loss. They don't like to admit that they really don't remember things, and they can get kind of aggressive about that. Disorientation, they don't know why they drove their car to the supermarket. I don't remember why I'm here. What did I get? What did I need to get? I don't know. They can get disoriented even in their own house. They don't know where they're at. They can become confused, and it's really scary for them. So they also have impaired abstract thinking. So abstract thinking is kind of a type of thinking that involves symbolic or hypothetical situations. They are unable to do this. They cannot think in the abstract. It's very confusing for them, and they are just not able to do this. Apraxia is when you are unable to perform a learned movement, like grabbing a glass of water. They know that they want to grab the water. Their brain is telling them to grab the water, but for some reason they just can't. They can't actually grab that and pick it up and take a drink. And that's super frustrating because they know what they want and they can see it right there, but they can't grab it and take a drink. So that is one of those symptoms that usually causes a lot of frustration with these patients. And then changes in personality and affect. They're very labile with their moods. They can be super happy and calm and sweet one minute, and then something will happen and it'll kind of just set them off. And they're angry and they're aggressive and they're kind of just like having these outbursts. It's a very like a roller coaster ride of emotions sometimes for these patients. Stages of Alzheimer's. First stage. This is the stage where it's really easy to brush the symptoms off. Like, it's just beginning, family's around, and they see it, but oh, it's okay. Grandpa's 80 years old. You lose your mind when you're 80 years old. That's not true. It's Alzheimer's or some form of dementia. So memory loss, lack of spontaneity, they want to stay home because that's what's familiar to them. They like being in a familiar area, so they want to stay there. Subtle personality changes, disorientation to time and date, all happen in this phase. And these can be present for a while, and then family members start to take notice, or the patient would even take notice of this. But again, they're really easy to write off as just old age symptoms. So it's not until they get to stage 2, and this is when it becomes very apparent that there is something wrong. It's not just old age. And the patient usually can tell at the beginning of this stage. they know that something's wrong. They know that their cognitive function is just not there. And this is when usually people start to seek treatment instead of stage 1. So impaired cognition, abstract thinking again, restlessness and agitation, especially with this sundowning syndrome. Have you guys ever heard of sundowning? Yeah, it's a real phenomenon, and honestly, it's actually quite incredible, and that might be the wrong word to use, but I have seen it so many times with patients that come in for something and okay, they have Alzheimer's. That's not why they're there, but okay. And they're sweet all day, they're great, and then like 4:30, 5 o'clock hits, and they are just like aggressive, like right about now. They're aggressive, and they're wanting to go home, and they're trying to hit you, and they're scared. It stems from a place of fear because they don't know why they're there, and they don't know what they're doing, but it is crazy, and then night, they sleep through the night, they wake up in the morning, and they're fine. It's a weird phenomenon. No one really knows like what causes this, but it's a real thing, and I'm sure like you guys probably know someone with Alzheimer's or dementia, and this is a real thing. And it's scary if the patient is living at home and this happens, because if they're living with their wife or husband, they might not know what to do. They might think they're in a dangerous situation and they could just leave home because they don't want to be there. So this can be very dangerous for patients. They can't carry out activities of daily living. They need help bathing, dressing, eating, doing just basic things. Impaired judgment. If you put a patient with Alzheimer's and in front of a crosswalk and told them to cross the street, they would not be able to judge like, oh, I can go now when there's no cars coming. They would not understand that concept. Inappropriate social behavior. This can also come in the forms of like inappropriate sexual behavior. My grandma actually has Alzheimer's, and she is definitely in stage 2, and she actually is kind of in this mindset where she is a teenager again, and she thinks she's young, and she just like playfully flirts, and it can like be very off-putting to some people, but she does this. She has inappropriate social behavior because of this. Repetitive behavior. Another example for my grandma, she would be perfectly happy organizing all of her little perfume bottles on her vanity all day long. She just walks over and kind of organizes them and then walks away and then, just kind of fiddles with them and moves them around, and she can do that all day. She's super happy doing that. So repetitive behavior is another one. This is the stage where it becomes very apparent that something's wrong with the patient. Family members know, the patient can sometimes know as well. And then stage 3, this is the final stage of Alzheimer's, and it is characterized by emaciation, which is basically just the state of being excessively thin and wasted. From the cancer PowerPoints that Laura showed earlier, that patient who had just like skin and bones, that's what Alzheimer's patients can look like too, because they don't want to eat and drink. They are just indifferent to food or water. They don't care. They don't want to do it. You can make them their favorite foods and they just won't eat it. One thing that I saw, actually, that I actually really liked you guys might have seen it too, is this student. He was like at a university and he made these like water drops for his grandma with dementia, and they're just like these kind of, almost like they look like candy. They're like bright colors, and they have like a sugar coating on the outside, and then they're filled with water, and so she could get calories and water when she ate them, and they were brightly colored, so she liked to eat them. I thought that was kind of cool. Something to think of. Inability to communicate. They are incontinent of bowel and bladder, and they lose orientation of themselves and to others, which this is really hard for family members, to see their mom or their dad like this, and they don't know who they are anymore. So it's hard. It's really hard. Treatment and diagnosis. So diagnosis made by ruling out other causes. Do a history. They can do a mental status exam, which they have them like draw a clock and say, put the hands on the clock at 2:30. They aren't able to, again, it goes back to abstract thinking, they aren't able to correlate that. They have like word remembering exercises too. I'm gonna say apple, coin, and table, and then they'll talk for a little bit and say, what were those 3 words that I just said, and they won't be able to remember those. Brain imaging, you can do a structural imaging, which kind of tells you the shape, the position and the volume of the brain, like an MRI or a CT. And then there's functional imaging, like a PET scan that can tell you like how the cells are using the oxygen and the sugar in the brain. And those are also ways that you can diagnose Alzheimer's. But you can't definitively diagnose it until you get a biopsy or an autopsy once the person has passed. If you do get a biopsy, the presence of both amyloid and, I can't say this word, hyperphosphorylated tau, okay, I think that's it, in the frontal cortex will be present in that biopsy, and that's also a way to diagnose it. Treatment, directed at using devices to compensate for the loss of cognitive function. So memory aids, maintaining a state of hygiene, good nutrition, just trying to preserve whatever cognitive function they have. And then there are medications, cholinesterase inhibitors, and these basically block the breakdown of acetylcholine. And acetylcholine is the main neurotransmitter for attention, learning, memory, and motivation. So if you're not breaking it down, you're going to have more of that left in your brain, obviously. And that can actually slow the progression of the disease and help these patients a lot. Aricept and Namenda are the two most popular ones. This is a recent study that came out a couple years ago, and basically it's a study that says that insulin may be able to treat or at least prolong the disease course of Alzheimer's. They found that insulin resistance in the brain is a common feature in all Alzheimer's patients, which is very interesting. I had no idea about this. So they're looking into it, but maybe in the future insulin can play a role in helping keep these patients, with more cognitive function than they have. This is just the research articles that I found, if you guys are interested. So I think Alzheimer's is kind of a concept, or a very hard and difficult concept to learn because there's just so many things going on. So this is just like a flow sheet that I really liked that explained the disease, the side effects, how family can feel about it, and how you can reduce the risk of losing your mental function by all these, which I liked too. So just something for you guys to look at. Parkinson's disease. Parkinson's disease is a degenerative disorder of the basal ganglia. Basically, the basal ganglia stops producing dopamine for whatever reason. Onset 58 to 62 years. It's usually found in males. No family tendencies, not hereditary or anything like that. They think that it might be a genetic mutation that people have. It could also be a viral cause. Herpes simplex virus, Epstein-Barr virus, CMV, varicella zoster virus, measles, polio, HIV, West Nile. These are all the main viruses that can potentially cause Parkinson's. And then environmental toxins. These would include things like pesticides, carbon monoxide, and the metal manganese. I can't pronounce that. But these, again, are some of the environmental things that may cause Parkinson's in people as well. So, there it is. This is kind of a flow sheet of the patho of Parkinson's. The basal ganglia stops producing dopamine, and then that whole pathway just sort of degenerates. So you have a loss of dopamine and an increase in acetylcholine. Acetylcholine is excitatory, dopamine is inhibitory. So you have this really bad balance of those in your brain. And then because of that, you have the three main symptoms of Parkinson's, which is tremors, rigidity, and bradykinesia. Because you're too excited, your muscles are too excited, and there's not enough dopamine to tell them to calm down, basically.
I know those three.
So these clinical manifestations. So tremors, they're kind of like, they're constantly tremoring. It's just like this little movement that it's mostly in the upper body, but it's just this constant tremor. And then they also have this stooped posture. They kind of hunch over like this, and they shuffle with their gait. They just like move very slowly like this while they're tremoring, and they have horrible balance because of this. They're a huge fall risk. If they're walking on anything other than flat floor with no carpet, these patients usually fall really easy. They're usually not safe to be at home by themselves in the later stages of this disease. They need help with a lot of things. And bradykinesia is just slow movements. Sorry, I forgot to say that. So again, classic symptoms: tremor, rigidity, bradykinesia. This tremor is a very unique tremor to Parkinson's. Sometimes people tremor, when they're writing or if they're using their fine motor skills. This tremor is kind of constant with Parkinson's. It's always there. And one thing that's unique about Parkinson's is it has this type of tremor called a pill rolling tremor. And it's an alternation of movements between your thumb and the index finger, and they kind of just go like this. And once they are trying to do something purposeful, like pick up a water bottle, that movement will stop, and then when they go back down to just kind of resting, they'll go right back at it. And I actually have a video of this because I think it's very interesting.
Hi, I'm Dr. Brian Harris, and I haven't.
Oh, maybe it won't show. Do I have to do something different with the screen to get it to show? It's okay.
We can show it at the end.
Yeah, there you go. We'll show it at the end. But that is a very unique Parkinson's symptom. So, other symptoms, autonomic nervous system symptoms. So they have uncontrolled sweating, increased sweat glands, they drool, they are constipated, they can retain urine, they have slurred speech. Fine motor skills can be really hard for them to do, and it's just it's a hard disease for these people to live with. All of the sebaceous gland secretions are caused by the autonomic nervous system basically in overdrive because of all the acetylcholine in their system. Treatment. Diagnosis, they do a history, they do a physical. There's no real specific diagnostic tests, but again, they can pretty much diagnose it from the specific symptoms that they have. The good news is with Parkinson's is they do have a medication called Cinemet, or it's carbidopa-levodopa, and this just is basically dopamine. They can just increase the dopamine. So we're losing dopamine because Parkinson's is a degenerative disorder, which the dopamine is depleted or destroyed, but we replace it with the medications, and we can lessen the symptoms that go along with it because of that. You can also use deep brain stimulators if medications and when they don't work. And deep brain stimulators deliver these electrical impulses to a targeted area of the brain that disrupt the abnormal activity that occurs with Parkinson's. So they can kind of stop the symptoms of Parkinson's. This isn't cure, this is just symptom management at this point. But it does work. I've actually seen these put in on patients, and it does work. So it's actually a really cool thing. All right, Huntington's. Huntington's disease is also called Huntington's chorea. Chorea is just a movement that basically it's irregular movements and unpredictable muscle movements. They're restless, they're fidgety, they are kind of just always like moving. And it's usually in the upper body, so it's also called that. This is a hereditary disease, which is scary because it can be passed on to their children. So it's an autosomal dominant disorder. So if one parent, that's the word I'm trying to say. If one parent has the condition, 50% of their kids are likely to get the disease, which is really scary because this disease doesn't usually show symptoms unless you're 25 to 45. So usually by that time you're already having kids or thinking about having kids or planning a family at that point, and you might not even know that you have Huntington's until you show symptoms, and then there's a 50% chance that you pass it on to your children, which is really scary. They think that the genetic defect is in Huntington's is on chromosome 4. And I just liked this graphic of these kids would be okay, but these kids, because dad has the gene, would have Huntington's. Mom does not, so that's why the 50% are okay, because you have to have one parent with the gene if it's a dominant disorder to have the trait. So Huntington's is, again, severe degeneration of the basal ganglia in the brain, but this is different from Parkinson's because it forms these tangles of Huntington proteins. They collect, and then these chains of glutamate's really sticky. They kind of just form and they stick together and they form these plaques inside the brain. And when neurons form plaques, they don't work. Neurons die. They're not meant to be in these little tangles and plaques. So the neuronal loss is associated with memory loss, cognitive dysfunction, and personality changes. There's also a decrease in GABA, which is an inhibitory neurotransmitter, which can alter the motor neurons and the mental function inside the brain. So this is a very common theme with a lot of these disorders, is there's neurotransmitter that are out of whack somehow. There's either an excess or a loss of them in some way. So symptoms of Huntington's: abnormal movements. Dyskinesia is basically on involuntary movements. So they're not trying to keep shaking their arm or keep fidgeting their arm, they just do. They can't control it. The coriform movements is kind of this dancing or writhing of the limbs and the facial muscles. It's different from dyskinesia because these are usually larger groups of muscles, and it can happen on one side of the body, like just one side, and it doesn't have to happen on the other side, or it can happen all over. And we'll watch this video at the end too, but this video shows it's really good visual of a patient with Huntington's, and he's in the doctor's office, and the doctor, is telling him to do these simple commands, and he is just kind of like, his arms are just kind of going, and then his leg kind of pops up, and his head is kind of just turning, and he just can't control it. He knows what to do. He knows what the doctor is asking him to do, but he just can't control his muscles. Cognitive changes as well: loss of memory, slow thinking, restlessness, irritability, impulsive. These are kind of unfortunately, the cognitive changes with this. Oh, and I forgot to talk about dystonia, I'm sorry. Dystonia is prolonged involuntary muscle contraction, so it's a long contraction of one group of muscles. It's almost like when you get like a cramp in your leg or your foot or something. That's not a dystonia, but that's like what it is. So. Treatment. You can't definitively diagnose Huntington's, but they go off of family history and symptoms, and they can diagnose it that way. And these abnormalities can be present for 15 years before the symptoms actually show up, which is also scary. That's why it develops a little bit later on in your life. Treatment. You can't halt the disease, but there is symptomatic treatment. Speech therapy, physical therapy can help. Xenazine is the first medication that the FDA approved for Huntington's, actually, and it just helps suppress the jerky motions with Huntington's. But it can also cause really bad depression in patients that are already prone to cognitive dysfunction and restlessness and depression anyway. So it's kind of a double-edged sword, but it works by having these anti-core effects, and it increases your dopamine, serotonin, and histamine levels, is what I read. So they also have antipsychotic medications that they can use to treat Huntington's, like Haldol or risperidone, but these medications are not ideal because they treat Huntington's by suppressing the symptoms, but they also can cause sedation, which is not good. They can cause you to just be like more out of it too, but that can be an off-label use. MS. Multiple sclerosis. This is a pretty common one. I feel like there's a lot of patients with MS that we treat every year. MS is a chronic inflammatory disease that involves the degeneration and demyelination of the CNS axons. And so myelin, remember, is the fatty covering that protects the nerve cell fibers in the brain and spinal cord. And MS can attack the neurons, but it mostly just attacks the myelin itself. So myelin is important because it keeps the messages flowing between the brain and the spinal cord and then the rest of your body. So when you don't have myelin, these messages can be slowed or even completely blocked. and this causes motor function issues for patients. MS is an autoimmune disorder, so your body is attacking its own healthy tissues for reasons that we don't know why. And then, you know, it's a huge chronic inflammatory disease. So I know you guys went over the acute inflammation pathway, which is the vasodilation, your permeability increases, you have the cellular infiltrates, the byproducts are removed, you have the clotting and all of that pathway. The chronic inflammation pathway is different because, as you know, it can happen after acute inflammation or without acute inflammation ever even being there. But anytime chronic inflammation is there, it's going to cause changes in cellular replication, which is what happens with these patients. With MS, the chronic inflammation can contribute to the scarring and lesions that are formed in the brain and the spinal cord. It comes on usually 20 to 40 years when patients are in that age frame. I've seen it in a couple pediatric patients actually recently that were like around, I think one was like 11, which was really sad. More common in females than males, but males can have a more severe and progressive course of the disease. And MS is unique and it is characterized by exacerbations and remissions. So, and we'll talk about that later, but as the disease progresses, you get more exacerbations and they last a lot longer, and the remissions get less frequent and shorter in duration. Okay, so like we talked about, it can occur when a previous viral insult to the nervous system in a genetically susceptible individual can just cause this autoimmune process to just kind of go off. Examples, Epstein-Barr virus and the human herpes virus can also be another one. And these viruses, if you have whatever type of genetical makeup, if you get these viruses, you are more prone to get MS. And then the autoimmune process starts, which causes demyelination of the nerve fibers and the white matter, brain, spinal cord, and even the optic nerve. So, again, autoimmune is a reaction against self-antigens and destruction of your own tissue. So what happens with this process is these autoreactive T and B cells, they can cross the blood-brain barrier, and they cause a huge inflammatory response. And then they start to attack the oligodendrocytes, which produce the myelin. So they start to destroy the myelin, and if you don't have oligodendrocytes to replace the myelin, you get the brain atrophy, the lesions, and the inflammation in the brain. And then when that myelin is also destroyed, the nerves, they can't conduct their messages. So that's the main symptom with this. You also get the activation of macrophages in the brain, which can also contribute to inflammation and injury by destroying the myelin along with the T and B cells. And then once they've, destroyed the myelin and the nerves are kind of exposed, they form these plaques and lesions on the brain that you can see in an MRI or a CT, and it's just like, I kind of want to call them like, they're just like scars. They're just like huge inflammatory scars on the brain. So they don't know if the inflammatory process is directed against the myelin or against the oligodendrocytes that obviously produce the myelin, but either way, they form these lesions, and they have inside these macrophages, lymphocytes, and plasma cells in them. Once they are through with this process, oligodendrocytes are decreased or absent, and then the white matter decreases in the brain and the gray matter increases. So white matter diseases in MS cause symptoms like numbness and weakness. They deal more with like the motor functions. And then the gray matter, when there's too much gray matter in the brain, that can cause more cognitive dysfunction. So too much or too little of either isn't good. But a lot of the MS disabilities actually come from cognitive dysfunction, which is related to gray matter. Triggers to having an exacerbation of MS. So exacerbations happen when it's a delayed or blocked conduction caused by inflammation or just a huge demyelination process. for whatever reason, and that signal cannot get through. So a couple different things can happen prior to an exacerbation, but it's not, these things don't have to happen. Trauma, stress, pregnancy are the three main ones, but sometimes you can just have an exacerbation without these three even being there either. So it kind of just depends on the person and how far along they are in their MS disease course. When you recover from these symptoms and you kind of go back into remission from the exacerbation, that's because the inflammation has gone down and you restore your nerve function because of that. So these are the classifications of MS: remitting, relapsing, primary progressive, secondary progressive, and progressive relapsing. You can kind of move down through them as the disease gets worse and worse. Initially, people with remitting relapsing without treatment, they transition down all the way to the progressive relapsing. But recovering again from these symptoms during remission is usually from the restoration of axonal function, either by remyelination or the resolution of inflammation. But over time, the frequency and length of relapsing will increase, and relapsing will increase, and then there'll be less and less time in remission. So symptoms of MS, they depend on where the lesion is in the brain, or the spinal cord is what symptoms they will have. But these are all the cranial nerves. So speech, vision, muscle strength, gait, coordination, balance, gaze, just your eyes working. All aspects of your motor function are affected by MS. And if you have like a bigger inflammation on your optic nerve, when you have exacerbation, you might really not be able to see very well or have blurred vision the whole time, which is very disappointing. But it really depends on where the lesion is and how big it is. These are some other symptoms of it. Paresthesia is tingling, like the pins and needles that you feel sometimes they like shoot down your legs or shoot down your arms. It's usually temporary, but it usually occurs in the hands and feet. Visual defects, again, clouding, double vision. Pain, when they move their eye, it can be painful. They can kind of just stare off into space too. Fatigue, vertigo, speech disturbances, bladder sexual dysfunction. These are all symptoms of MS. And these really affect patients' everyday life. It's a huge disease that is very detrimental to them. This is a picture of just all if you're a visual person, like I am, all of the symptoms of MS for each body system. So this was, I really like these studies, so I thought I'd throw them in there. But this study basically found that certain inflammatory disease activities in different parts of your spinal cord or your brain can actually predict the course and how long you're going to have MS, which is really good because we don't have a way of saying like you're going to have a really severe course of MS that's going to last your whole life, or you might have a mild course that you have not a lot of exacerbations in. But this study found that, however, what the inflammatory markers are, I don't know, but they could detect them on the MRI and potentially predict that for people, which that was really cool. Treatment. So you can diagnose this disease with a history, a physical, and then an MRI. You can see the plaques and the lesions that MS forms on an MRI. And then you can also, IgG or immunoglobulin G will be in the central spinal fluid, and, cerebral spinal fluid. And this is done by a lumbar puncture. And high levels of IgG actually can mean you have any autoimmune disorder, but it's usually used to help diagnose MS. Treatment, you can take anti-inflammatory drugs to help decrease the huge inflammation processes that are going on in lesions, steroids, immunosuppressants. These are great drugs, but they have a lot of side effects with them, especially if they want patients to stay on them for a really long time. They can have a lot of different side effects, especially the immunosuppressives. You're at huge risk for an infection, and if you already have MS and you get an infection on top of that, it can be really hard. Symptom management and then prevention of complications. These patients, their motor processes are definitely messed up. So if they fall, and they get a hemorrhage, that can be very detrimental to them. A plasma exchange can be helpful if people don't respond to the steroids too. That's also something. Regular exercise, speech, and physical therapy can help as well. ALS. ALS is an interesting disease. It's also called Lou Gehrig's disease. So this is a neurodegenerative disorder, again, that involves the upper and motor neurons. Causes progressive muscle weakness. This happens over a long period of time. Usually happens when you're about 50 years old, more common in males than females. Cases are sporadic. Again, we don't know what causes it. It's kind of a common theme for all of these diseases. Genetic mutation possibly could contribute to it. There's a binding protein, 43 is a major constituent of the protein in ALS, so they think that might have something to do with it. But really what it is glutamate toxicity causes neurodegeneration. So glutamate is an excitatory neurotransmitter, but too much glutamate can cause, it just like excites cells to their death, basically. They just excite and they die. And they don't have enough energy to sustain that excitement for very long. So in ALS, the transport of glutamate out of the cells is stopped or slowed, so there's a toxic level of it inside the cells, which causes the neuron to die. So this is the motor neuron degeneration without inflammation. That's what makes it key from other diseases. There's no inflammation in this disease. And it's the upper and lower motor neurons, but the sensory system and the whole brain really remain intact. So these patients know their disease course, and they know what's happening to them, and they know, everything that's going on, and they can feel everything, but they just can't move, which is terrible, right? I mean, I don't know if I'd rather not know what's happening or know, but it's a really, really sad one. The acute chronic pathways of inflammation do not happen with this disease. I just wanted to reiterate that. So it starts off really slow. It's like a slow progressive weakness. It usually happens in the limbs first, arms and legs, and then it kind of progresses inwards to the trunk and the core of your body. Fine motor skills, manual dexterity is really the first thing to go. Usually these patients will be confined to a wheelchair. They'll need help with, all activities of daily living and eating and drinking and all of that stuff. They can retain maybe little to none movement as the disease progresses in their limbs, but that's if they're lucky. Later on, difficulty swallowing, difficulty speaking, very stiff muscles that are kind of contracted on themselves. And then this disease kills patients because their lungs become paralyzed after a while. They can't breathe, so has respiratory failure. And again, they know what's going on the whole time. Their cognitive system remains intact. Do you guys know the famous person that had ALS that died recently, a couple years ago? Stephen Hawking. Do you know who Stephen Hawking is? Yes. Okay. Good. Ooh. He was an astrophysicist, and he was like an incredibly smart man, and he had ALS, but again, his brain was intact. So he did a bunch of amazing stuff even while he had ALS, and he actually had the disease longer than anyone else. He lived with it for 55 years before it killed him, but that was the longest anyone has ever lived with it. All right, treatment, history, physical exam. You won't have any other neuromuscular disorders. You'll just have this. You can also do an electromyography, and that is basically something that records the electrical activity of muscle tissue, and they can kind of see, do you have a lot of muscle or activity here, or not here, but here, and then they can diagnose. Medications, Ryalutech is an anti-glutamate, but it can just extend the length of time that patients don't need veterinary assistance, but it can't cure it. But it works by blocking the release of glutamate, and it just slows the disease process and helps with symptoms, but it's not a cure. Symptom management, prevention of complications, and psychological support, because as you can imagine, this disease is very hard to deal with, and where people can get depressed and anxious and have that's a horrible way to live. But, all right, and myasthenia gravis. So this is also an autoimmune disorder, and in this autoimmune disease, there's antibodies against the acetylcholine receptor at the neuromuscular junction. So for whatever reason, these antibodies attack the receptors, so acetylcholine cannot bind to the receptors. We'll talk more about that. But you can kind of see in this picture how this is a normal neuromuscular junction, and the little green dots are the acetylcholine, and they're binding to these receptor sites right here. And then in myasthenia gravis, you have these antibodies that bind to the receptors, and so the acetylcholine cannot. And acetylcholine, you guys remember what it does?
It initiates a muscle contraction.
Yes, it's an excitatory neurotransmitter, yes, and it elicits a muscle contraction, perfect. So, these antibodies produced against the receptors, they block the binding of acetylcholine, and then, again, like we said, acetylcholine, it is an excited neurotransmitter, and it cannot cause the muscle to contract or move if it can't bind to the site. So the antibodies destroy the receptor sites, they have diminished transmission of nerve impulses, and they can't depolarize the muscles, which if you can't depolarize the muscle, you can't move the muscle. So this is just another picture of a normal muscle versus a myasthenia gravis muscle. But again, like most of these diseases, we don't know what triggers this autoimmune process. It just kind of happens, which is so frustrating. I would love to know what causes these diseases, but. Okay. So symptoms of this disease is fatigue and progressive weakness. Usually the muscles in the face are affected first. The eyes are definitely the first one, I would say. So this is a normal gaze. When you tell someone to look up, they kind of can just move their eyelids up and they look up. With myasthenia gravis, they have ptosis, or the drooping of one eyelid. They'll kind of, I can't really demonstrate it, but they'll look up with one eye and they won't be able to move this eye very much. So that is definitely one of the hallmarks of it. The muscles in the face, the mouth, the neck, the chest, it kind of progresses down that way. And it can kind of look like stroke-like symptoms, if this cheek isn't really wanting to move, it can droop a little bit. And I think immediately we think of stroke like right away, but it's actually this. So they can have, drooping of the corners of their mouth, they can have some drooling, their eyes. Muscle fatigue is super common. And again, progression varies with this disease. Appears as a mild case first, and then, you relapse into another more severe case, and you have some intervals where you don't have any symptoms, but over time the disease will progress. What do you guys think, if the muscles in the chest are affected, what is a huge concern with this disease?
Breathing?
Yes, yeah, you can't breathe if your chest muscles don't work. So respiratory arrest is actually a really big concern with these patients, especially as the disease goes on. So again, these kind of just cover what we just talked about, but facial expressions, mastication, they have a really hard time chewing and swallowing food. Speech, it can just kind of be this monotone speech that doesn't really have like the highs and the lows, and it's just kind of monotone, and it's the same tone, and that's it. And again, impaired ventilation. Another thing with the swallowing and the chewing is aspiration. So not only do we have to worry about them choking on their food because they're not not chewing it well enough, but they are also like having a hard time breathing, so maybe they can't cough that out. It's a bad combo. So there's two different types of crises we can have with myasthenia gravis, a myasthenic crisis and a cholinergic crisis, and they have relatively the same symptoms, but they're very different in what causes them. So for a myasthenic crisis, there's very low levels of acetylcholine, and with a cholinergic crisis, there's actually really high levels of acetylcholinesterase, because it's actually caused by a drug toxicity. So with a cholinergic crisis, there's like just too much in that cleft that's just not getting absorbed. And myasthenic crisis is there's just not enough. So that's how they're different, but they basically present around the same way. With the cholinergic crisis, the thing that's different is there's increased intestinal motility, your heart rate can slow, and you can get really, really sweaty, and this is caused by the smooth muscle hyperactivity, because there's so much acetylcholine in your body. So both can lead to respiratory arrest though, which I think is very important. So how can you tell if someone's having, what crisis they're having? Because really they might be having the same symptoms when they come to you. So there's a drug called Tessalon or Indoforium. Same drug, just different names. And basically what it does is it's anti-cholinesterase drug, so it inhibits the breakdown of ACH and increases the concentration of it. So what do you guys think? Which crisis would this be good in? When would you see an improvement in symptoms if you gave this drug? Yes, I know the answer is but yes, there is an improvement because it increases the number of acetylcholine in that neuromuscular junction, so hopefully some of them can bind and they can get their symptoms relieved. But a cholinergic crisis, there's no improvement or a worsening of symptoms because you're just putting more acetylcholine into that junction where there's already like a super, super high amount. So, and then, when acetylcholine binds, it can help the muscles contract and they can breathe better, they can, open their eyes, they can move their face more, and it works immediately. I've seen this given once, and it was like an immediate turnaround for this patient. They were having a myasthenic crisis, but it was very interesting to see. Okay. Treatment, they test your response to the Tensilin, and there'll be an immediate improvement in muscle strength if you have a myasthenic crisis going on. They can also do the electromyogram, which again is the electrical activity in your muscle. They can do antibody titers, but treatment again is mostly symptom management, steroids, immunosuppressants. This disease the exacerbations can last for like a really long time and gradually get better, but it can take a really long time. And this disease is another hard one because so many of the muscles that are affected are in the face, and so it's hard for people to go out with this disease, and if they're having some drooling or drooping and they can't raise their eyelid, it's very embarrassing for them as well. Okay, so I just have a couple questions for you guys. Don't worry if there's not many, just want to make sure you're paying attention. What are the classic Parkinson's symptoms? You could just yell them out, you don't have to raise your hand. Perfect, yep, the tremors, the rigidity, and the bradykinesia. Slow movements, they're really rigid, and they have that slight tremor at all times. So. Which age group does Huntington's disease usually first appear? C, yep, around 30s to 40s. Right when you're starting to have kids, and yeah, you might need to pass the disease on to them. Usually people with ALS die from what? Respiratory failure, perfect. Yep, their lungs cannot function anymore. Motor neurons are shot. Signs of Alzheimer's include which of these symptoms? D, yes, all of them. They lose their memory, they can be be irritable, they're super restless, all of those symptoms. MS affects the CNS. Which part is usually attacked? B, yep, the myelin. Perfect. Great. That's it, guys. Do you guys have any questions about this? Perfect. Okay. Sounds good. Well, thanks for letting me come and talk about this.